Good morning, everybody. My name is Faris Haddad, and it's my great privilege as Director of ISEH to introduce you to the ISEH's first Sports Cardiorespiratory Medicine Conference. It's really great to have you with us. The Institute of Sport, Exercise and Health, or ISEH, as you may see it referred to on the screens, and today was set up as a partnership between UCLH in London, UCL, HCA International, the British Olympic Association, and the English Institute of Sport as a 2012 London Olympic legacy project. It was one of the founder members of the National Centre for Sport and Exercise Medicine. And our remit throughout has been to enhance performance, to deliver management of sports performance and sports injury across the entire population, and to improve disease and prevention and health and physical through exercise and physical activity in the UK and internationally. We have dramatically expanded our remit over the last couple of years, and thanks to Professor Matt Wilson and his team, we've seen a dramatic and really very impressive improvement in the delivery of services and in the scope of what we're offering, both on a teaching, training, and also on a research perspective. But one of those key facets that's really made huge progress over the last 18 months with and in spite of COVID has been the expansion of our cardiorespiratory services. So today really is a celebration of the great work that Matt, Jim Hull, Guido Pires, and everybody around them has been doing. I hope it is the first of many such meetings. As you'll hear from Matt in a moment, we have an absolutely outstanding international faculty with you today with some great presentations and hopefully some lively discussions. So welcome again. It's great to have you on board. I hope that we will one day see you face to face at the Institute. But for now, let me hand on to Matt Wilson, who really is the brains behind all of this and the driving force behind what you're going to be involved with today. Matt is a professor of sports science and the head of sport and exercise medicine at the Institute. And over to you, Matt.
Good morning, everybody, and thank you for joining us, and thank you for those kind words, Faris. It's a great pleasure to welcome everybody today to our first cardiorespiratory conference. We hope this becomes an annual event, and next year we will see you face to face and engage, and hopefully get away from the online presence, although I doubt we'll ever really truly escape it now it's embedded in our culture. We have a really wonderful program today, split into a morning and afternoon session. The morning focusing on optimizing respiratory health and protecting athletes from respiratory illness. In the afternoon, the common sports cardiology conundrums for an SEM clinician. Now, we've packed it into one day, and we've cherry-picked the questions that we are routinely asked in our daily clinical practice. We could have had a 2 to 3 day conference on each of these subject areas, but we've really tried to highlight the key areas that we're facing. I specifically want to thank our international delegation. We have David Pyne linking in from Australia, Michael from Vancouver, Martin from South Africa. This afternoon we'll have Kim from Seattle. So thank you for staying up late into the morning or getting up very early to accommodate us. I won't spend too long, I think we'll just get cracking. I won't spend too long going through each of the individual bios because our chairs can do that with each talk. So I'll jump straight into the first talk, which is Dr. James Hull, what are the big issues in sports respiratory medicine? Now, as Faris says, we've worked very hard in the last 18 months on our respiratory services. As many of you are aware, that respiratory issues and gastric issues remain a highly prevalent issue in all Olympic Games, all World Cups. It seems to be the #1 medical issue. And so we've launched a service that has really thrived here the last 18 months. We've launched a service that 18 months. James Hull is leading that. He's a consultant respiratory physician here at the English Institute of Sport and at the Institute of Sport, Exercise and Health, Institute of Sport, and the consultant respiratory physician at the Royal Brompton Hospital. His specialist areas are in chronic cough, persistent throat symptoms such as discomfort and closure, and unexplained shortness of breath and asthma. So having said all of Jim, the floor is yours. For the delegates, for the conference attendees, you'll notice on the bottom right-hand side there is a Q&A box. Please feel free to ask any questions you may have. We've dedicated a good 10 minutes at the end of each presentation. We've noticed that some of our talks have been a little long, so we've shortened them to really try and have a good engagement with the participants and the audience. So feel free. I will moderate that, and we can have a good Q&A after every single talk today. So, Jim, the floor is set. Over to you, please.
Okay, so it's my great pleasure also to welcome you to this first ever ISEH Sports Cardiorespiratory Medicine Conference, or perhaps it should be better termed a Respiratory Cardiomedicine Conference. And of course, that's important because we're kicking off the morning session talking about everything to do with sports respiratory medicine. So my task in this very first opening session is really just to try and set the scene and cover what I think are the really big or contemporary issues in sports respiratory medicine. For those of you who don't know me, I work for the majority of my time as an NHS respiratory consultant at the Royal Brompton Hospital in London, but I also run a dedicated sports respiratory clinic at the ISEH. I'm also involved as an advisor to the English Institute of Sport and to various anti-doping bodies. And I think probably of most relevance to many delegates on the call, I've been contributing to an International Olympic Committee and also a British Thoracic Society guideline on athletes' sports respiratory medicine, which I hope to see out in the next 12 months and should really hopefully provide a useful background and information on the things we're going to talk about today. So what do I want to cover over this first session? Well, I've divided the talk into two parts really. I first of all want to open up and talk about what I think are the big global issues or challenges when we think about respiratory health in athletes. And then I'm going to move on to talk about a slightly more granular level and individual issues and the challenges when I see people in a sports respiratory setting. We're going to talk specifically about some clinical cases. So I think you as the delegate body know anyone who partakes in sport, particularly endurance sport at an elite level, has to breathe a lot and breathe for long periods of time. And that often has to be done in potentially very noxious environments, very cold or dry air, very dusty or polluted environments, and often with individuals breathing in chemical substances that are around and about. It's a real breathing challenge for anyone who's athletic. And so it shouldn't be particularly surprising, this is data very kindly shared from the English Institute of Sport and Craig Ransom, that respiratory tract issues are a #1 medical problem within an elite sports performance system. And so here you see data over a time period where you can see that respiratory tract type symptoms and presenting for a clinical assessment of those problems is the most common medical reason an athlete seeks care and far outstrips other musculoskeletal or indeed other medical problems such as gastroenterological problems. So a really important problem. And don't take just this cross-sectional audit word for it, but look at the number of different papers which look at illness and injury surveillance data across international sporting events, including Olympic Games and Winter Sports Championships. And you consistently see that when you look into the data, respiratory illness is the #1 key health and illness signal that comes through in this data, and that's consistently seen across these events. If that wasn't bad enough, just add on to the mix this little spiky ball that we've all been having to deal with over the past year. And it's remarkable to me that it's over a year now since myself, Mike Loosemore and Martin Schwellnus from the Institute published this Lancet piece talking about respiratory health in athletes and some of the issues we thought athletes had to face with the COVID-19 challenge. Of course, it was relatively controversial at the time because people were really concerned with the very high mortality of this condition across the general population, and things like trying to obtain increases in intensive care unit beds. But we thought it was right to try and argue some of the important points for the health of athletes. Of course, also within the Institute at the time, we tried to provide documents and guidance for athletes in terms of their own safety for exercising in the context of recovering from COVID. And then this BDSM editorial with Matt Wilson as the lead author, talking about some guidance and advice on return to play and safe return to play after COVID. And I think this really speaks to one of the key points and one of the key reasons that I've tried to set up this morning's session in the way that you'll see and the way that I'm going to talk about on the next slide. And that's for us to really become much more savvy and focused on what we can do to try and protect the health or the respiratory health of the athletic population. Too often in my mind that's overlooked, and of course it's a key driving sentiment of the Olympic movement to try and do everything we can to protect and maintain athlete health. And so it really is my great pleasure to welcome the number of speakers that we've got for you this morning. And they literally do come from every corner of the world, and they're going to cover a broad and fantastic range of subjects, right from infection and COVID, through to pollution, through to the immune system, and things like how we can protect the surface airway, particularly in athletes who are exposed to particularly noxious environments. I'm going to talk about how we can get the best out of breathing as well during these sessions. So I'm really, really looking forward to what the speakers can bring today. So let me just turn my attention now to what I think are the big individual issues or challenges within a sports respiratory service. And I suppose if you're looking for a silver lining in the cloud of COVID, what I would say is that for our service, and probably the same for you, we've been able to access individuals in a far greater range now, where we've been able to set up really good remote services so that I've been able to consult athletes in South Africa, various parts of Europe, in America. And so it really is a step forward in terms of being able to help athletes right across the globe. If I think about the individuals that I see within our sports respiratory service at the Institute, then of the individuals we see, probably top drawer fall into this category which I call asthma type. So they're breathless when they exert themselves, they have a wheeze often, sometimes they have difficulties with trying to obtain a satisfying breath, and it's affecting their ability to perform exercise both at the recreational and the competitive or elite level. Often see individuals with recurrent chest infections, which appear to be unexplained, and I'm going to talk a bit about how we tackle that in a minute. And then there are a proportion of individuals who have either unexplained chest pain or an unexplained underperformance, and we've been running a post-COVID clinic specifically for athletic individuals now for some time, and I hope that's proven to be very helpful to individuals returning to sport. This is a typical case, not actually a patient of mine, but a nice video illustration of a typical case that we would see in the Institute with someone who reports the difficulty of wheeze and breathlessness and being treated as being asthmatic, because when you hear those constellation of symptoms, then of course the obvious answer must be exercise-induced asthma. But let me just run this video just to show you the type of symptoms she gets when she's been running hard. And hopefully you could hear that prominent wheeze, the distress, the breathlessness, and that's very typical of the type of case that we would see. And I tend to start off when I see patients, of course, like all of you probably will, with a clinical assessment and thinking about trying to interrogate some of the key features in that clinical assessment. It's important to really focus in on the intensity and the characteristics of the symptoms. Do they occur at peak exercise? Do they build such that really when someone is, for instance, in a bike race and they're attacking or they're going up a very steep climb, the symptoms are maximal? Or are they symptoms which come in after exercise? Someone who runs outside in the cold weather, comes back inside the house and then feels very tight-chested and can't breathe? Or really, are they completely chaotic? You can be breathless just going up a flight of stairs, but it can also be during running and it's all over the place. I also think about the localization of symptoms. Do they tend to occur in the upper part of the chest and throat? Is there an associated wheeze on breathing in, or is it lower down in the chest and the wheeze tends to occur on breathing out? How do inhalers affect symptoms? Can the symptoms actually be very nebulous and respond to different types of treatment at different times? And as many as you won't be particularly surprised to hear, this is the way that we set up the clinical assessment of the differential diagnoses for these asthma type presentations in athletic individuals, such that these symptoms or this symptom constellation and timings tend to be associated with this condition called ILO, or exercise-induced laryngeal obstruction, where the voice box is closing in and tightening in during vigorous exercise, very common condition, often overlooked. EIB, or exercise-induced bronchoconstriction, also present, of course, as a phenomenon of exercise-induced asthma. And of course, we measure lung function post-exercise because that's when symptoms occur most commonly. Or this third entity, which again seems often overlooked, BPD, or a breathing pattern disorder or dysfunctional breathing, again very common in athletic individuals and still sadly often overlooked. But one thing that doing this type of work for the last decade or so has taught me is that you cannot rely on a clinical assessment or clinical history alone. In fact, lots of studies have now shown that you might as well really toss a coin in the air to try and see if the diagnosis is accurate based on the symptoms that an individual describes. And that might be because the wheezy noise or the breathlessness of ILO sits very closely or often overlaps the entities of EIB. So it's very difficult to try and navigate your way through that without doing some decent high quality tests. And so here you see two videos. This is an individual doing a test called EVH, eucapnic voluntary hyperpnea. It's the gold standard test for diagnosing EIB. And you breathe in this very cold, dry air for 6 minutes, and we look at lung function before and afterwards. And you can see the test here with this individual really working hard, and in fact probably has dysfunctional breathing because they've got lots of apical excursion, which I'm sure Julie will talk about later on, but a very, very good test for ruling out exercise-induced asthma as a problem. And this test here, where we place a camera, a flexible laryngoscope just into the back of the nose, and it looks down and sits and looks at the voice box and gives us a continuous view of the larynx to see whether it's closing in the condition of exercise-induced laryngeal obstruction. And this test is called a CLE test, which is becoming much more widely spread widely available across the world, and is the gold standard test for the diagnosis of ILO. So you'd think at this point you've done a good clinical assessment, you've progressed to undertaking high quality objective testing, that things would be pretty straightforward. You just need to select the right type of asthma inhaler. Of course, it's important to check that the patient or the athlete takes the inhaler and they're taking it in the correct way, but things should be pretty straightforward from there. But so often they're not. There's often overlapping problems from different parts of the airway, coexisting nasal disease, sensitized to different allergens, different seasons, which have different contributions to overall symptoms, particularly in athletes racing in different environments, for instance, in Europe. Laryngeal closure, interacting with nasal problems, causing you to breathe when you have a blocked nose with an open mouth, which dries out the larynx and then precipitates the laryngeal symptoms, which cause discomfort and irritation and may predispose you to laryngeal closure when exercising. Problems with the breathing pattern because the asthma might not be adequately controlled, which then feeds into abnormal patterns of breathing, which then cause anxiety about not being able to obtain a satisfying breath, which then falls into a feedback loop which continues to amplify the symptoms. Issues from things such as gastroesophageal reflux, again contributing to potential for cough and breathlessness. And that's even before we start to think about other factors such as obtaining and ensuring immune health against the type of infections that we've all had to deal with, for instance, over the last year. So it's a complex interplay, and it isn't simply good enough to say we've made the diagnosis of asthma and that's the end of the story. So often, as I'm going to show you in a second, all of these issues overlap and are present in the same individual. So let me show you some data just to substantiate this as my sort of closing statements for this opening talk. And this was a paper we published as a collaborative effort just at the turn of the year. And it was really based on the approach that we've been using in difficult to treat or severe asthma for a number of years, particularly at the Brompton. And essentially, in the study in patients with difficult to treat or severe asthma, what we've done for many years is we've tried to look at all the components that I talked about on the previous slide and unpick those so that when we see an individual, then we can start to work through what are the different contributory factors, and if we can treat them, then we can optimize overall respiratory health in a systematic way. And so I was very fortunate to be involved with this group, with a collaboration that came together between the Institute of Sport, Exercise and Health, Imperial College, and the EIS to be able to conduct some work in individuals in the elite system within the EIS who were struggling with supposed unexplained recurrent respiratory tract infections. And individuals were invited to come along and to do a number of tests in this SARA type assessment, where they come along and they have a number of questionnaires that are filled in, and then they have these comprehensive tests which start to look at all the different components of a respiratory health assessment, including looking at nasal flow, lung function, the challenge test that you saw called EVH as a gold standard for asthma, some allergy testings, and the results are reviewed. And those, for instance, who were asthmatic already, things like optimizing their inhalers, optimizing their inhaler technique, thinking about immunizations. And we divided this population up into those who were deemed to be susceptible to respiratory tract infections and those who were non-susceptible. And you can see the definition there at the top of the slide, based upon what we thought was a reasonable definition of respiratory tract infections having an impact on an elite athlete's training schedule. Something that might actually affect their performance if they were continuing to get that type of event, and thus reduce their availability for training. And you can see quite nicely these populations were generally well matched. Of course, the individuals who were susceptible had a much greater history of these different types of respiratory tract ailment. And I haven't got time to show you all the detail on that study, but what I would say is that when we looked and classified the prevalence of different abnormalities based on those different characterizations that the athlete went through, we were able to see that some of the very common abnormalities we see were sinonasal problems or rhinitis in just about 50% of athletic individuals, and far more common in susceptible athletes. And likewise, asthma or EIB was very common. But the biggest differentiation, which I'll show you on the next slide, was in things such as laryngeal dysfunction, very prevalent in individuals with susceptibility to respiratory tract infection. Some groupings of the conditions that we saw co-localized, so as you might expect, things like allergy, seasonal rhinitis, and asthma seem to, on a heat map, be present in the same sorts of individuals, whereas laryngeal dysfunction or breathing pattern dysfunction, again, overlaps and were more common in these hierarchical cluster models. And so these conditions are there, they often overlap in the same individual. There are clusters or groupings of the different types of entities. And when we look specifically at the odds ratio between those who are susceptible and those who are non-susceptible, some of the strongest signal surprisingly came out in individuals who had a signal of laryngeal problems or laryngeal dysfunction or breathing pattern dysfunction. So it wasn't just the presence of asthma or rhinitis that might signal out an individual who is more susceptible to respiratory tract infection. And I think that's novel, and I think it adds the potential need for focus in that area. So I'm very pleased indeed to some doctors within the sports medicine community who authored this BGSM blog, which is free to access, and talks a bit about the focus on respiratory health and highlights some of those factors in a simple way. Of course, the next step, of course, is to think about randomized or prospective studies to see if we can intervene with some of these abnormalities and then show a signal in the reduction of respiratory tract illness in an elite performance system. So I think that probably brings me in on time, and I'm going to bring this first talk to close. Of course, there's plenty of time for Q&A so that we can talk through some of these issues in more detail. But what I want to do is summarize this first talk by just saying that when we think about the big global or contemporary issues or challenges, surely respiratory health must be right up there. In the general population, we're thinking about pollution, we're thinking about infection risk, and I think there's more we could do to try and think about that, particularly in elite athletic populations. And we need to think about the environment that athletes actually partake their sport in and make sure that's as safe as possible for their lung health. On an individual level, it's about getting the diagnosis right. You can't issue the right treatment unless you know that you've got a secure diagnosis. And I've already shared some data and discussed the fact that listening clinically and trying to make an assessment is often very inaccurate. But when you have a diagnosis and you think the work is done, think again, because you must think systematically about the other issues which overlap. If you really want to optimize respiratory health, then you need to think systematically, constantly, in every case. I'm going to finish there. These are my contact details. Of course, we have written a book on some of these issues that will be covered today, which I'm shamelessly plugging here. But if anyone wants to contact me, doesn't have enough time in the Q&A sessions, then these are my contacts, and please feel free to contact me. Thank you very much indeed.
Thank you, James, for that wonderful introduction to set the scene for the rest of the day. For the audience, the Q&A box is in the bottom right-hand corner. If you do have questions that you'd like James to answer, then please type away. But in the meantime, I'll go first. In terms of ILO, just how common is it, and what are the typical characteristics you would find that would point someone to think that ILO might be an issue here?
Well, thanks, Matt. I mean, I think ILO is actually very common indeed, and it's often and continues to be overlooked, sadly. We did a study looking at the park run. Many of you will know or partaken in the park run on a Sunday morning, running around a sort of muddy field in different locations in the UK particularly, but globally so too. And what we did was we looked at people partaking in that event and running in at the final funnel, and we listened to see whether they had a wheeze, and if they had a wheeze, was it a wheeze breathing in, a so-called stridor, which is characteristic of the closure of the upper airway. And what we found in that study was that about 5% of people running in had that stridulous sound. And often actually those individuals were grabbing for a blue inhaler at the end of their run, when in fact probably the problem was coming from ILO. So we think that actually it's about somewhere between 2 to 5% of young athletic individuals, and there is data from Scandinavian countries which would substantiate that this is a common condition, and it may be as common as exercise-induced asthma or exercise-induced bronchoconstriction, particularly in young individuals under the age of 25.
So in terms of a practical application for the audience to take away from this, where do people, where can they get explored for ILO? Where can they have this investigation done? And if they don't have access to it, but they suspect it, what can they be doing?
So it's an excellent point, and it remains the case certainly within the UK that it is difficult to access the very best diagnostic tests for ILO, which I think I showed in the presentation. The gold standard test is to put a little camera in the back of the nose, a look at the voice box, and then get someone to actually do the sport that brings on their symptoms. What I suggest is that the first thing to do is to make people aware of the condition, and ask them also to try and record like a selfie type video when they're performing their sport. So hold a phone up when you're going out for a run, or when you're finishing an intense session, record what the wheeze is like, and then take that to your clinician or your physiotherapist and say, this is what I'm like when I get my symptoms. And the characteristic sound of the inspiratory wheeze, potentially also the dysfunctional breathing, should be evident on that video and should alert people to at least think about the diagnosis. That's yet to be validated in these sort of prospective studies, but I think it's an important stepping stone. And then from there onwards, you can move forward to trying to pursue centres with expertise and with other tests as you need it. But often you can try and intervene and use some treatment early on, which I'm sure Julie's going to talk about a little bit later on this morning for us.
Yeah, so not to preempt Julie's talk, but in terms of breathing pattern disorder, you mentioned it as quite common, a third aspect to think about. In terms of indications for a breathing pattern disorder for people, many athletes are in their mid-20s, don't realise they have a breathing pattern disorder, and have been competing at a very high level for a number of years. What would be the things that would trigger a breathing pattern disorder in your mind, and point a clinician to say this is an issue?
Yeah, again, I think this is a really overlooked issue, and is very prevalent in athletic systems when we do studies to look at the impact of this condition. I think there's things. Often it's a diagnosis of exclusion. So people have had tests for asthma, they've had consideration for cardiac tests, and there isn't an explanation that's forthcoming in terms of why they're struggling with their breathing. And it seems disproportionate. So people with a breathing pattern disorder might, for instance, report that they're okay when they're jogging at a steady pace, but if they simply try and go up a flight of stairs, they feel profoundly breathless. And it seems really disproportionate for an athlete who's used to really competing at a very high level, suddenly to struggle with breathlessness going up a flight of stairs or bending over. And that triggers that sort of thought process. It's a bit disproportionate to what you might expect. And often when I see people and I look at their patterns of breathing, and I really don't want to steal Julie's thunder, but essentially, the movement of the chest and the way that they breathe in and out has some very characteristic features which should alert people who are seeing these individuals to think, this could be a breathing pattern irregularity.
So if you take, let's take a good adolescent athlete that's on an upward trajectory to making senior squad. What would be a standard annual respiratory screening profile you would do compared to an adult athlete?
So, I mean, screening is a really interesting issue. And I know much of the afternoon is devoted to cardiac screening, but it still seems remarkable to me that actually, when you think about the presentation of clinical problems or symptoms, respiratory symptoms far outstrip cardiac symptoms, of course. So, fortunately, you're screening for cardiac issues, which may, and in the vast majority of athletes, never cause any problems. You're looking for, obviously, the risk of cardiac death, and you're looking at potential risks for maybe dysrhythmia and other things, but you're not actually trying to detect a symptomatic problem. And yet, if you flip that around the other way for respiratory side of things, we know that probably 1 in 4 endurance athletes have some sort of problem with their breathing when they're exerting themselves. So to me, it doesn't seem very logical to try and discount the ability to detect problems that are going to be relevant in terms of a symptomatic athlete. So I would say that, athletes do need better approaches to screening. And they, at the very least, should have some lung function tests, for instance, spirometry, and potentially spirometry in the context of exercise or some form of a provocation test, especially in those who answer positively to a screening questionnaire, such as the AQUA. So, that at the very least. And things like allergies are important. Things like nasal disease are very common in groups like swimmers. And so, it seems remiss not to think about all of those things and some of the things that I talked about in a systematic way.
In terms of linking that into underperformance and recurrent infections, in terms of immune function, taking the holistic approach, the consequences of that, what's your thinking about the athlete that has a recurrent upper respiratory tract infection, or linking that into a GI issue? How common is that you're facing in your clinic?
So the next speaker is I'm sure, going to cover this in some depth. So again, I won't preempt or steal his thunder. But what I would say is that, yeah, it's very common. I mean, and as I identified on one of the early slides, it's the key potential performance impact of any medical condition on an elite system. So it's a huge issue. And I think the IOC has recognised that, and alongside things like mental health of athletes, concussion management, the next big priority area for the IOC is respiratory illness. And what is interesting is, often when we think people get respiratory symptoms, we just assume that it must be an infection straight away. But often it's an inflammation, or it's a sensation, or it's a hypersensitivity of some of the nerve endings within the respiratory tract. And so it isn't always just an infection. And I think that speaks to the last few slides that I showed, which suggest that those who were deemed to be susceptible within the English Institute of Sport system, we found signals of laryngeal dysfunction when they were well. And that might hint at the fact that actually there is hypersensitivity within the upper airway tract, which then is presenting as what looks like respiratory tract infection, but actually is more a manifestation of these hypersensitive type phenomena that we see in the general population, and I certainly see every week in the cough clinic that I run at the Brompton.
A question from the audience: when we look at cardiac screening, our window to start screening would be in the 12 to 14 years of age. The expression of inherited heart disease, comes in your adolescence. In terms of respiratory health, when would you start assessing these athletes for respiratory issues? We know that many academies will see athletes, elite swimmers, 10 to 12 years of age. It's particularly for ILO. What's a lower age limit?
Yeah, we've just published a piece from a collaborative piece of work between a number of Scandinavian countries and some centres in the US, which looked at the characteristics of individuals presenting with ILO. And we found that it was the predominant age of presentation was somewhere between the ages of 12 and 15 for ILO. There was 1,000 individuals referred to our different centres. So you're quite right. ILO tends to present in younger individuals. And also, I mean, the key point to make about this is that might be a stage, or is a stage really, in an athletic career progression where athletes are often trying to make it into national teams or international teams, particularly for swimming. And so not getting that diagnosis correct at that point, has actually major consequences on career development. It isn't good enough, like I see every week, to see athletes who are 17 or 18 and say, yeah, my asthma's still bad. It's been bad for 5 years. And it was never asthma, it was ILO all along. So that's the age to intervene and detect this problem for sure. With respect to asthma, I mean, there is evidence, and maybe Pascal Kiplin will be talking about this later on this morning, that, over the course of an exposure to certain environments, particularly swimming, I'm thinking of, people develop airways hyperresponsiveness or reactivity. And therefore, we see it develop in adolescent swimmers as they're exposed to longer and longer times in the pool. And so it would be interesting to see what her thoughts are later on about, when we should screen or when we should think about doing asthma-based tests in adolescent swimmers as they develop through their career. It's important, finally, just to say that, your lung is still, and your airways are still developing up to the age of 25. So we've got to protect the respiratory health of young individuals because their lungs are still growing to 25. And if you alter that trajectory of lung development, it never gets any better. It's downhill, I'm afraid, all the way from 25 onwards.
Sorry to go back to ILO again, but for the naive amongst us, how is it actually treated?
So essentially, once you've got the diagnosis correct, that's the first thing to say, then the mainstay of treatment is therapy-based treatment. So, and I'm sure Julie will touch on this later on, but essentially what we're trying to do is use breathing techniques to try and modulate the way that air enters into the laryngeal area. And if you can modulate that, then you can affect the flow and you can affect the pressure gradient in there. And that can be very beneficial for lots of individuals with this. If that doesn't work, people are absolutely, struggling, and they've got, for instance, an athletic career or a professional athlete, then we do undertake surgery, and that's principally for the structures which are folding in over the top of the larynx in a small procedure called a supraglottoplasty. And we've operated on a lot of international and Olympic and professional cyclists over certainly the last 5 years.
Another question here from the audience. The role of CPET in assessing airway health and the clinical diagnosis for unexplained shortness of breath, for example.
I mean, as many of you know, I love CPET, and I do hundreds of CPETs every year. It's a fantastic tool for people who are relatively profoundly limited or are struggling a lot on a day-to-day basis. It's more complex to use in an athlete context, in that you've got to have some understanding or benchmark from where you think that individual should be at. So, the individual you might test may still have a peak oxygen uptake of 130% predicted, but previously they might have been 180% predicted. So you've got to be able to use it in the right way for the right individual, especially in the context of athletes. Having said that, it is a useful tool if you've got individuals who are exercising and they develop breathlessness, to assess two things really. One, to listen for the stridulous sound, but two, to look at the attenuation of inspiratory flow on the flow volume loops in real time. And secondly, to measure the FEV1 immediately after the exercise test in someone who is symptomatic. It isn't a good test to diagnose exercise-induced asthma because you're using a mouth, often a mask or a mouthpiece, which is moist, and the air isn't very dry, so it isn't a good test in that context. But if they're symptomatic and the FEV1 hasn't dropped post-exercise, then it's quite useful in saying, look, there isn't evidence in this context when they're symptomatic of EIB causing their symptoms.
Jim, we're almost running out of time here, but a final question, and one that I have no idea on, but is ILO linked to the silent acid reflux as currently diagnosed by a lot of ENT specialists in non-athlete cough?
Yeah, I mean, reflux is a really tricky area, and I spend a lot of time thinking about reflux in the cough clinic for sure. If it is anything, it is going to be the non-acid reflux probably, which is causing the problems. So the enzymes which break up the food in the stomach, which spill up in a gaseous form, and that's why it's so difficult to diagnose. So even if athletes don't necessarily report characteristic reflux symptoms, heartburn, acid sensations after they've eaten, it may still be relevant to try Gaviscon Advance to try and suppress the non-acid reflux. And I often ask people about belching or whether they feel like they're overly full after ingesting food. We need better tests to really diagnose that and to work that forward, but there hasn't been a strong signal of reflux as a driver to ILO in the studies available to date.
Jim, we're going to close there, and thank you again for a wonderful introduction to a fantastic day. And I'll let you chair the rest of the session and introduce David. For the audience, please continue to ask your questions. They're fantastic, and great for the rest of the day.
Okay, well, thank you, Matt. So hopefully we're going to queue up and introduce the next speaker. So look, it's my massive pleasure to introduce Professor David Pyne. He's a research professor at the University of Canberra and is joining us all the way from Australia. He's got a massive history of very high quality publications, particularly in the area of immune system function and infection in athletes, which is the main reason why I've invited him. I've been working with him on the IOC committee on this area over the last year, and it's always a massive pleasure to be able to spend time with him on the call and to talk about this area, which I think is, thrust into our consciousness even more so in the context of COVID. So his title of his talk is The Immune System and Respiratory Tract Infection. How can we protect athletes? I'm massively looking forward to this. Thank you, David.
Thank you. Thank you for the introduction. And it's my pleasure to speak to the conference today. And I would like to acknowledge the Institute and the organising committee for the opportunity to present to the audience today. And it looks like a pretty good program across the morning and the afternoon. So my topic today is around the immune system and respiratory health and infection. My background comes from Australia, the Australian Institute of Sport and the University of Canberra. And I've had a background as a sports scientist and a researcher in sports performance, athlete health and exercise immunology. And today I'd like to share you some of my insights from that long practical experience, research work and observations where we are in 2021. So really this audience would know no introduction, I guess, to the overview of the immune system. But what I'd like to do is probably take a look back as to where we've come from over the last probably 25 years in terms of our understanding of the relationships between exercise, training and the immune system. As we know, the immune system is divided, a complex network of both the innate and the adaptive arms, comprising both cellular and soluble elements. And really my journey began, as probably many others in this field, quantifying various cell counts. So enumeration of white cell counts in the various subclasses, and obviously using benchtop assays of immune cell function. And that served us very well through the 1990s and 2000s. In addition to the cellular evaluations, there was a lot of work done around the soluble factors in the antibodies, and particularly with myself and colleagues looking at salivary immunoglobulin A as a marker, and people have been chasing that one for a long time. So both cellular responses and soluble responses. But with the advent of technology, as everyone would appreciate, the advent of proteomics, metabolomics and epigenetics has really transformed the field. And I'd really like to just speak briefly to that. So really it's using the latest tools to evaluate these relationships between exercise and training. And our most recent work is really focusing now on T cell function and the epigenetics of T cell, looking at CD4, the T helper cell, and CD8. And a lot of this latest information really comes from clinical medicine, so various applications in clinical diseases, and trying to translate to the athlete population. So that work is going on at the moment, and that will bring new insights, better diagnostic tools, and to evaluate the immune status of athletes, and also to evaluate the effectiveness of various interventions that I'll present today. In terms of, I guess, the latest thinking, I refer you to a recent review article commentary from my Scottish colleague, Ricky Simpson, a long time now resident in the US in Arizona. And there was a very topical debate in that journal last year that gave a really good, I guess, contemporary insights to the questions, the controversies, and the future directions around exercise, the immune system and training. And ultimately, it's really to try and assist athletes, coaches, and the clinicians to ensure our athletes stay in good health or return to good health after a period of absence through illness or infection. To address this question, I really have 3 points today. So with the idea about protecting athletes, I want to address that at 3 levels. One is at a larger organisation level. Secondly, at a team level, and thirdly, at the level of the individual athlete. And a lot of this does come down to individual responsibility. The whole world is preparing now in terms of elite sport for Tokyo 2020 in the Olympic sport domain. And obviously we're down to 90 odd days now. And still a lot of uncertainty as to how that's going to play out, both from an organisational point of view and then obviously team preparation and the individual athletes. But we can think about protecting the immune system athletes really down that hierarchical chain, if you like. I also point to, I guess, our roles in this process. So in this audience and in our colleagues in our professions, we have the frontline clinicians, the sports medicine practitioners. We have the allied health practitioners, the sports science practitioners, of which I've had a long history, the various students and graduate students and registrars. We have the researcher, and that's really my main focus in more recent times. We can play roles as an educator, either for education on the front line directly to coaches and athletes, or as an educator in terms of organisation and teams, or really in a more academic setting. And then obviously we can serve in various administrative roles with international, national or local organisations as officials. So I think our profession has a lot of ways to address this issue, be it as a frontline practitioner or behind the scenes as a researcher, or in the important roles of education or organising coaches and athletes in terms of guidelines, policies and practical tips for athletes. In terms of, I guess, that broader organisation, I know in the UK you refer to that as the national governing bodies, the NGB, and in Australia it's the NSO, the National Sporting Organisation, and obviously the larger national organisations in terms of Olympic committees. So really those larger organisations have the responsibility for these activities in terms of preparing teams and athletes for competition, but particularly, I guess, in a sports medicine setting. So really around planning of activities and programs in the season leading up to major competition, the scheduling of sports science and medicine services, that could be early season screening or provision of services at competition or training, or more clinic-based scheduling. Obviously, it comes down to resourcing in those various settings. And as I said, that apart from delivering frontline services, there's the ongoing role in education. And we'll do our best in terms of Tokyo 2020, but it is important to take the opportunity to look back. So after each major competition, or World Championships or an Olympics, it's really about reviewing what's gone on. So I think as sports medicine practitioners and officials, we play a role in all those areas in terms of preparing organisations for major sport, as we have this year for Tokyo 2020. As an example, here's a snapshot from the Australian Institute of Sport. This is on the website, and this is the framework for rebooting sport. Obviously, this comes out of COVID 2020. Updated now, as you can see there, for March 2021, so just a couple of weeks ago. And this is obviously an outward-facing web page, and you can see here the various tiles. And I'm sure, many of the leading nations would have something similar. There's been a plethora of material that's come out at various organisational levels. So those tiles and the issues that they address would be fairly commonplace, I'd imagine. And obviously, COVID sits front and centre in terms of these plans, but in terms of ongoing illness protection, a lot of these issues really cover the basis from, I guess, routine clinical presentations, obviously through to what we're all addressing now in terms of COVID-19 and SARS-CoV-2. So again, a part of our role is in the preparation of information for these sort of web-based resources. So that's certainly a role for sports science and sports medicine practitioners to play. At a team level, and now we're thinking here in an Olympic domain, preparing for all the 29 or 30 different sports, and obviously in professional team sports, there may be 1 or 2 frontline practitioners and then other allied health practitioners who are assisting that. And obviously these areas of focus and priority are pretty common, so there'll be no surprises in this list. And a lot of this really is around limiting pathogen exposure to protect the immune system and to protect the athlete. So again, this is the team level, and then cooperation within a team between team management, obviously the athletes themselves and other team personnel. And the sports medicine practitioner, again, plays a role in these preparations, probably on the ground, during trips away as a frontline sports medicine provider, and obviously in the larger competitions at the Olympic Games. So again, we have important roles to play at a particular team level. But what I wanted to really focus, I guess, is what's happening with individual athletes. And this is the lens that most people view this question about protecting athlete health and the immune system. So very early in my career, I came up with this 5-factor model, and you can see there, over 20 years ago, training strategies to maintain immunocompetence. So this is not a new issue. It's brought into focus now with COVID-19, but as we exit that in the years ahead, these will remain, I guess, as critical factors. So training load management, particularly in those high-intensity endurance sports. I'm sure we're all very well aware of the importance of psychological health for athletes and mental health, which is becoming increasingly in focus. There's the environmental exposures, really around, I guess, temperature, altitude, air pollution, but these days around infectious exposure, lifestyle management, and again, sports medicine practitioner. There's some really good resources here. My colleague Martin Schwellnus, who will be appearing shortly, and colleagues have written a number of review articles and consensus statements, a lot of those featuring the British Journal of Sports Medicine. And also Jason Edwards and my colleague Neil Walsh, originally at Bangor, but now at Liverpool John Moores, around the role of psychological stress and the immune response after exercise. So there's a lot of information available in the scientific and medical literature, and it's a matter of bringing that together and then trying to implement that in a practical setting. In terms of my interest as an exercise and sports scientist, these are critical questions, particularly in those endurance sports, as I mentioned. So we're thinking of the running, the cycling, the triathlon, rowing, and swimming. So, these are obviously things that are understood by coaches and athletes around training volume and intensity. And obviously in those high volume and work-oriented sports, these are daily challenges of managing training and fatigue. And my long-time colleague Carl Foster from the US wrote this summary over 20 years ago and really identified the importance of these factors in terms of overload, increasing the risk of immune disturbance, and obviously increase in presentation of illness. And Carl's obviously known as the Dr. Session RPE, and he's just written a 25-year retrospective on that Session RPE concept, which is very widely used in sports around the world. What I would like to address now are the risk factors. So we've talked about training stress and about travel stress and environmental factors. Here's a study that I was involved with my French colleague Philippe Hilliard from the French Swimming Federation, involving 4 years of medical surveillance. And here we see the odds ratio of illness in relation to these various factors. So training factors, the competition, whether national, international, and obviously the winter season. So what we can see here is that training itself only has a small effect in terms of an increased presentation of upper respiratory illness. So a 10% increase in training loads leads to about a 10% increase in the odds of a respiratory illness. If we go down to those with repeat or recurrent illnesses, certainly that leads to a doubling of the risk. So prior history, as illness or infection prone athletes really have quite an increased risk, and much greater than probably an increase in training. If we go down to the winter season, almost a doubling of the risk, so 1.9 times the odds ratio for illness in the winter relative to summer. And probably the critical one here is the one at the bottom, and this comes from Ida Svensson's work with my colleague Mike Gleeson, formerly of Loughborough University, in cross-country skiers. International travel, 4 times the risk. And again, that probably wouldn't surprise anyone in the audience today. So training has a small risk. The season and the winter season, increased risk, and international travel probably brings the highest risk. So I think you can factor those in terms of the priority of planning and management on the ground with athletes. In terms of lifestyle management, and this is where the athlete really needs to take individual responsibility in relation to their coach, team management, and their sports science medicine backup. So obviously athletes will have their own history, and some of those are illness prone. We've talked a bit about the training load. We know that dietary factors are important for immune health, and as are sleep and obviously personal hygiene. So again, no surprises there, but it's trying to package those up and how important are these and how much of a difference do they make. And a very recent study, again from our colleague Martin Schwellnus, and I hope I'm not stealing your thunder, Martin, if you're going to present all this shortly. So here's a study again published just last year in the British Journal of Sports Medicine. So a 7-year study of illness in Super Rugby in the Southern Hemisphere, and really looking at this intervention, and these are all the standard things, aren't they? So medical screening, close hand hygiene, social distancing in a rugby team environment, early intervention and isolation of infected individuals, and international travel prophylaxis. And the critical results here, so this is the incidence rate in the first 3 seasons before this plan was implemented. And we're seeing, you can see the number of illnesses here, and an incident rate of 6.5 episodes per 100 player days. And that reduced after the 4 years of this intervention program by about 50%. So down to 3.2 episodes per 1,000 player days. So a reduction of about half by strictly following this program. So medical intervention, obviously team management oversight, and obviously player education. So following these very basic guidelines can make a substantial difference in an elite sport environment. I mentioned about nutrition, and there's a big story with immunonutrition that's probably worth another whole workshop. And again, I'm sure these areas are familiar. So the nutritionists and the dietitians will be promoting a food first approach before supplementation. Carbohydrates are important as a fuel source for training, exercise and competition, but also in terms of maintaining immune function. Been a lot of work done on probiotics, on flavonoids or polyphenols, and on vitamin C. And again, I refer to the work of Neil Walsh, Ralph Yeager here with the probiotics, Stefan Beaumont, both athletics and swimming in terms of immunonutrition, and a very recent sports medicine review on flavonoids and polyphenols. So my take on that is that these nutritional, both macronutrients and micronutrient and supplement intake can yield small variable benefits, but more work is needed for specific guidelines. And you've probably been hearing that for quite some time. So the research evolves and continues on, but there's small progressions in our understanding and then I guess the implementation, and I guess in the formulations of these foods, and particularly in the supplements. So certainly it's an area of interest both for the sports dietitian, for the sports medicine practitioner, and for all athletes and team personnel in food first approach, but then particularly if there's any individual needs or requirements from a supplementation point of view. In terms of medical aspects, and I defer to the expertise in this audience. I'm not a sports medicine practitioner. I come from a sports science immunology background. So I'm sure these are the topical issues that we'll probably hear more of today. So the importance of screening, prophylaxis, both antiviral and antibacterial. Obviously, there's the big discussion around SARS-CoV-2, and then these are the standard issues that are occupying a lot of time at the moment: diagnosis and management, and return to play. And again, my colleagues here today, your own James Hull, Martin, who will speak after me, and also a colleague in the US from Chicago, Carrie Jaworski, who's very active in the sports medicine space in the US and in the American College of Sports Medicine. So a lot of information in there, but it comes down, as it always does, to implementation. Finally, I'd just like to think ahead. So there's a lot of information, there's a lot of personal clinical experience, and these are great networking opportunities here today. So I see these as the areas ahead. So, we're hearing about personalised medicine. That's been coming for a while. I don't think it's arrived yet at the front line of high performance sport. I think the opportunity and the tools are there. So like that's still coming in terms of a competitive advantage with national teams or professional sporting teams. A lot of that's built on the technological advancements with point of care analyzers and obviously what's in the clinic and in the laboratory. And then it's about the digital communication. And we know that with COVID, how it's an inside outside. People are working from home and we can connect with anyone at any time around the world. And it comes down to team resourcing and coordination. But the critical factor, as always, is compliance from the individual athletes, the coach, and getting full engagement at an organisational level, a team level, an individual. So I just leave you, we all are in these roles and probably played several of them at any one time. So there's opportunities, whatever your role and occupation is to participate in this work. And that's work both at the front line in the clinics, but importantly, I guess, in terms of research and contributing to advancement of our understanding of the immune system and athlete health. Thank you.
Well, thank you very much indeed for a superb talk and very comprehensive, covered a number of really important issues. Just to remind people, if you have questions specifically now for this 10-minute Q&A session, which is open, then please enter them into the chat and we will endeavour to go through them as we chat through this session now. While you're thinking, what I might do is, if you don't mind, is open up with some questions. And I'm not going to ask you to give away the Australian Olympic team secrets here, but if you had an athlete that came to you and said, look, or within the system and said, look, what are the 3 most important things I could focus on to try and protect myself and make sure that I don't get infection, what would be your advice, or what would be the Australian system advice?
Yeah, thanks, James, and thanks again for the invitation to speak today. Yeah, that's the question that's on everyone's lips. And I guess with a young athlete, it's really teaching them to take responsibility for their actions and for their preparations, and to work closely with their coach and their support staff. So obviously there's a wide range of sporting situations with different teams and sports. So for the younger athlete, it's really about that self-responsibility and self-management. And obviously I'd focus in on those key factors that we identified in the talk, and a lot of it really is on that lifestyle management around, I guess, the exposure element, because obviously the analysis there shows that the training loads are probably a secondary factor, as are dietary factors. So I think probably the key factor is, as we're seeing now in COVID, it's really around that minimising pathogen exposure. Okay.
And people often talk about this sort of J-shaped relationship, or some people say even an S-shaped relationship between, load and the fact that as you become more of an elite athlete, there's this period where you sort of, start to become more susceptible, and then you go over the top of that when you're very elite at the top, sort of on the podium, where you seem to be protected against infection. What are your thoughts on that, and is there something we can learn from that?
Yeah, that's right. It's been around for a long time, the J-shaped curve. So David Newman, pioneering work back in the early 1990s, and that still holds to today with all our clinical experience, and I guess the research work supporting that as well. So certainly for high performance athletes, some of those, probably many of those, would reach a threshold where too much work might slightly impair their immune function, and then in the presence of pathogen exposure, obviously that's when they have an increased risk or odds of contracting an illness. So I think that one does hold up fairly well in a sports setting. But for the general community, I think we're looking at probably a broader spectrum from obviously the sedentary individuals through to the moderately active general population, through to the elite athletes. So as we know, the elite athletes are only a very small specialised population. And that 2020 paper that I mentioned, Ricky Simpson in Exercise Immunology Review, has got a nice discussion on that broader community level. So I think it really depends on who you're working with. So high performance athletes, you're looking at their load and self-responsibility. Probably for the broader population, it's really exercise and physical activity would be certainly a focus.
Okay, great. So a couple of questions coming through. What does international travel prophylaxis look like? What are the components that are important? Other things over and above the normal components you might recommend, such as wearing a mask or first defence and zinc. What are the sort of components or advice you'd give for people who are concerned about travel risk, getting to international competitions, etc.?
Well, we're seeing that play out right now, aren't we, in terms of the IPL in India with the cricket there. We follow that closely, and obviously preparations for the Olympics. So again, I just make reference to the work that I reported there with Martin Schwellnus, who should be following shortly, around those sort of 4 or 5 major elements. So some of that is obviously happens in advance in terms of screening, and then in the weeks ahead can be some of that prophylactic, antiviral, antibacterial, or the probiotic administration. So these things need to be discussed in the months in advance, and then there's that immediate period in the weeks before, and then obviously in terms of the flight itself. So obviously giving high priority to hygiene and isolation as best that you can manage within the constraints of long-haul international travel. So I know that's challenging at the moment, but obviously as we work through this epidemic, I think these are common sense precautions that athletes will need to adhere to in the future as well.
And don't sit near the back of the plane or front of the plane, or what would you say? Where should you sit as an athlete in the plane? Obviously, at the very front if you can get the tickets, but otherwise, is there a position to be in?
No, I don't think so. I mean, obviously there's been some publicity around the safety on airlines, and obviously there's the information coming in about the recycled air and so on. So I'm not an expert on ventilations. So it probably does come down to, again, those individual factors. But obviously on a long haul flight, it's quite tiring, and sometimes the guard slips. So one of the issues that we've faced is the athletes, been reminded so many times they tune out. So going back to the point I made in the clip there around education, so we give athletes a lot of education and maybe some reminders prior to flight, but even on the flight, and just making sure they're doing the right thing.
Okay, so just another question. We're coming to the end of the session, but a question about asthma and the interplay between asthma and respiratory tract infection. We know that probably within an elite system, maybe 15 to 20% of particularly the endurance cohort, will have a diagnosis of asthma or some form of airways disease. How does that interplay with risk of respiratory tract infection, or how we might look at that?
And that's right. I've done a lot of work in swimming, as you know, James, and that sport particularly has got a history of asthmatic children often come into the sport because that's something that obviously may be part of a treatment or a management regime. So really, it's going back to your point you made that we need to get onto these things early and screening in the teenage years, and so these things can be dealt with as they progress through their sporting career. And obviously, when they get to, say, the elite levels, that's just more the annual screening and close consultation with either their general practitioner or certainly the sports and exercise clinician. So it's both the short-term strategy and then the immediate strategy. And obviously, if athletes, both with an infection or inflammation or an EIB or exercise-induced asthma, it's that early onset and contact straight away. So we're very big on educating the athletes to put their hand up early because early intervention will lead to a better outcome.
Okay, great. We have got a couple more minutes actually. So I suppose one of the other areas which interests me is potentially, what is the normal carriage of bacterial or viral patterns within the airway? Do we have any data historically about the microbiome? It's become a sort of hot topic in general respiratory medicine, but is there data which suggests that the microbiome might be altered in athletes or make them more susceptible then to other pathogens which they're exposed to?
Well, the 2 points there. One is the first one about, I guess, pathogen detection. And there's been a long history of pathology testing, and that has evolved, with the advent of improved technology. Now, there's probably a proportion of athlete presentations that are viral, probably up to 40, maybe 50%. So the most common origin would be a viral. A smaller number of bacterial. There's probably a few that are more inflammatory oriented, maybe exacerbation through environmental temperatures or pollen or air pollution stimulants. So certainly that's important in terms of the pathology on that. So again, it goes back to that point about early consultation, early management. And from a clinician point of view, it's probably just cross-referencing with the experts in those areas. So there's been a lot of discussion about a general practitioner moving to a sports and exercise medicine practitioner, moving to a clinical immunologist or a respiratory expert such as yourself, James?
Okay, thank you, Dave. We've got one last question here from the audience. Is saying, is the risk of repeated short haul travel, so if you're in a professional cycling team, for instance, and you're flying around Europe a lot, is that the same, or can we have studies looked at that compared to a long haul flight? I know there's some data, I think I'm right in saying, that indicates that it's the direction that you travel which actually makes you more susceptible to infection, especially in long haul. But is there anything short haul versus long haul that is helpful for clinicians?
Yeah, there are some studies, and it's probably a duration of an exposure. So obviously long haul over 10 hours or 12 hours that we have to do, from down under in Australia, frequently the Northern Hemisphere. So it does show that there's increased risk of that long haul travel. You said repeated short haul travel, maybe more in the Europe and the continent and across in the UK, in other non-COVID times. Moving through airports, I think, are probably a risk as well. So it's probably a duration of hours of exposure. But I think those critical touch points in and around airports, hotels and terminals is a pretty important spot to be highly vigilant.
Okay, great. Well, listen, thank you again for your talk and the Q&A session. That's an absolutely fantastic presentation. Really appreciate you joining us as well from whatever time it is at the moment in Canberra. So thank you again, David. So we'll bring that talk to a close, and I'm going to introduce the next speaker now. So I'll just invite Mike to join us on the screen. Mike, can you hear us? Are you on the screen now?
I'm there on the screen, I think.
Yeah, great. Fantastic. So I think it's about 1:30 or 2 in the morning for you, isn't it?
Yeah, something like that, 2:15.
So listen, first of all, a massive thanks to Mike Koehle, Professor Mike Koehle, who's joining us from Canada. And he's going to present some work which I think is going to be really interesting and relevant to people who are certainly considering the travel arrangements for athletes going to Tokyo, talking about pollution, talking about ozone and the challenges of the environment, which I think is a massive area and needs a huge more amount of attention to it, especially within the elite athlete system. So thanks to Mike for that. And then we'll go straight into the Q&A straight after this. So thanks again, Mike.
My pleasure.
Okay, well, thank you to the Institute of Sport and Exercise Health for inviting me to this exciting conference and to give this talk. So my name is Mike Koehle, and I'll be talking about the impact of air pollution and ozone on athletes. And I thought I'd start with a little scenario. This is a real scenario from a couple of years ago. The World Athletics Championships, which is track and field, had the World Championships were in Doha in Qatar almost 2 years ago. And during the event, I got a call about the pollution and the effects on the athletes. And there's basically the sports science and sports medicine team were concerned about the air quality and its potential health effects on the athletes. In Doha at the time, there's a reasonably high amount of particulate matter in the air, and it was an interesting situation that at those World Championships, the race walk and the marathon started between 11:30 p.m. and midnight because of the heat. And so that was also when all the construction was particularly active. And so the concern was that these athletes may be competing at the highest pollution time. So the science and medicine team wanted some guidance on sort of mitigating those effects. And so that's the kind of question that you may get asked when you're working with teams, especially at major events or even with recreational exercisers. So I thought I'd step back and do a little bit of background. First on air pollution. Air pollution is a very heterogeneous thing. And so when we say air pollution, it can mean a variety of things depending on time of day, season, location. And I liken it to a dessert. You can't sort of say, well, dessert is bad for your health because of this or that, because dessert comes with many recipes. We've got the yummy looking thing at the top that's probably bad for your health, and then less yummy looking thing at the bottom that's probably good for your health. And there's no air pollution that's good for your health, but I think when we think about air pollution, we have to take into account the recipe. And when you make a recipe of air pollution, you make a mix of particles and gases. And the gases that are present in air pollution include ozone and carbon monoxide and oxides of nitrogen, among other things. And then particles can be liquid or metal, and they can be as simple as dust coming up from a road, or soot from wildfires, or pollen or particles. And so the makeup of air pollution is always changing, it's always different, and its effects both on health and performance vary depending on the constituents of the of the air pollution. In terms of exercise, we're interested in the acute effects of exercise on air pollution and air pollution on exercise, because exercise does a variety of things. It increases your metabolic rate, it increases your ventilation. In more intense exercise, you're going to be breathing less through your nose, more through your mouth, so there'll be less filtration. You'll be taking deeper breaths, so the pollution may get deeper into your lungs. And so there's a lot of theoretical reasons that exercise may actually exacerbate the effects of air pollution. And we can see that in the media here on the top right. We've got an article from Runner's World that's saying exercise when air pollution is high can do more harm than good. And then a competing article, this is from the Globe and Mail, which is the paper of record in Canada, and it says, dirty air affecting your health, pedal harder. And so as a consumer or a clinician or a scientist, how do we sort of reconcile these kind of differing messages? And so hopefully we'll be able to unpack that a little bit in this talk. So I'm going to divide the first part into health effects and performance effects, because they're different. And when you're working with exercisers, you may want to address them both separately. So in terms of health effects, if you only remember one thing from this talk, remember that air pollution is bad. And there's nothing good about air pollution. It causes lung disease, heart disease, hospitalizations, emergency room visits, mortality. It's bad for your health. And if you're attending this conference, you're likely aware that exercise is good both in the prevention of disease and also in the management of disease. And so the whole question, or the problem that we're trying to deal with, is to sort of reconcile the negative effects of air pollution and the positive effects of exercise, and look for any synergies between the two. So when we look at air pollution and exercise, we're really looking at an acute bout of exercise during times of high air pollution. And we've looked at a variety of systems, vascular, cardiovascular, and respiratory, and even cognitive a bit. And we use multiple models. We do sort of ambient air pollution or chamber exposures in laboratories. In terms of vascular outcomes, we've used endothelial function like flow-mediated dilatation, heart rate variability. We use this device here on the top right, the EndoPat. In one study, it's a sort of operator-independent endothelial function device. And we've even, as you see in the bottom right there, taken photos of the retinal vessels before and after air pollution exposure and exercise exposure. We've looked at this at different intensities and really haven't been able to see any exacerbation of the air pollution effect by exercise. And when we look at pulmonary effects, the story is pretty similar. We've looked at, again, two different models. We have done spirometry, the fraction of exhaled nitric oxide, looking at ventilation during exercise. And we've looked both in the healthy population and in a population with exercise-induced bronchoconstriction, specifically using the eucapnic voluntary hyperpnea test. And we really haven't seen any exacerbation of the air pollution effects at all. And so here's some data just from one study that's going to be published in the next month or so. It's available online. And this is looking at people with exercise-induced bronchoconstriction exposed to diesel exhaust, either with or without salbutamol, a bronchodilator, and during exercise. And you can see that the filtered air and the air pollution signal really overlap very closely. We get a big increase in forced expired volume in 1 second when they're on the medication, but really no difference between the two. And we sort of consistently have seen that effect across a number of studies, and are surprised at that because, for the reasons we already mentioned earlier on, you expect exercise to potentially exacerbate these effects. And so we looked around, and there have been other groups studying similar questions. In this article here out of the IS Global Institute in Barcelona, they had stationary bicycles over highway, and the participants were exposed to traffic. They looked at a lot of the same outcomes that we looked at, and that, again, they find that there is no exacerbation of the air pollution effects by the exercise. And even in epidemiological studies, this is a great study of 55,000 people out of Denmark, where they looked at their postal code and the air pollution exposure based on postal code, and looked at activity levels, and they found that the benefits of exercise weren't diminished by the air pollution. So we're not seeing this really expected health interaction effect. Here's another epidemiological study, again, finding very similar outcomes. The positive effects of exercise seem to persist. The negative effects of air pollution are there, but the exercise isn't exacerbating it, and that's a key message. Okay, and so that was the health side. Now what about the performance side? If you're working with athletes or competitive recreational exercisers, they're also going to want to know about how it affects their performance. There's less studies that look directly at performance, but there have been a few lately. We did this one where we looked at oxygen consumption during a 30-minute constant load cycling exercise test. And we were looking at the effects of exercise intensity, expecting that there may be greater effects at higher intensity exercise for the reasons that we had outlined earlier. And in fact, we didn't see many effects at all in terms of ventilation or lung function. The only three things that we saw was that we saw at lower intensity exercise a slight increase in metabolic cost during exercise that wasn't present in the high intensity exercise. So that was a bit counterintuitive. And we also saw that across intensities, there seemed to be more discomfort, both in the legs during cycling and then in the lungs in terms of dyspnea. And so in terms of performance effects, I think probably one of the key things that people may notice is the symptoms themselves more than pure performance per se. So they may feel a little bit of breathlessness, or the legs may feel a little worse. And so that's something that you can maybe reassure the athletes about. This is an interesting study that's published as an abstract in ACSM. These are our colleagues in the JEDI lab at University of Sao Paulo. It's led by Dr. Koehle Bertuzzi. They did a 50-kilometer time trial comparing filtered air to ambient Sao Paulo bad traffic air pollution. And you can see both in the duration of the time trial and in the power output, even over the course of time, there was no significant difference there. So we have not been able to show acute performance decrements from this sort of particulate exhaust traffic related air pollution. Okay. So everything that I've been talking about in terms of the research has really been sort of an acute exercise effect during air pollution, and then we measure them for a period of hours afterwards. With athletes, with exercisers, with major competitions, we want to think more than just the exercise bout. Remember that air pollution is bad for health. And what the data are showing us is that during that, say, 1 hour per day where you're exercising, there doesn't seem to be a huge synergistic effect, or the exercise doesn't seem to be aggravating the air pollution effects. That doesn't mean that air pollution isn't bad and that the exposure to air pollution for the rest of the day isn't consequential. And we have some perhaps circumstantial data to support that. One is this study where we expose people to diesel exhaust before an exercise bout instead of during, and we found that not only was their heart rate higher during exercise after exposure to air pollution, but that they didn't have the normal exercise-induced bronchodilation from exercise. And so that made us think that, you know, the pre-exposure may be important. Likewise, this fantastic study done out of Belgium, they did 3 seasons, 3 cities, monitored people for black carbon, so soot basically, exposure, and looked at lung function and exercise intensity. And they found that over this 7-day period that they measured the participants, there was a interference or diminution of the positive effects of exercise on lung function. So a really important message is that maybe there isn't a big effect during the exercise or immediately following the short-term exercise exposure to air pollution, but it's that entire day or 24 hours a day, 7 days a week exposure to air pollution that we think is harmful, and it's probably actionable as well. So I'm just going to talk about some potential mitigation strategies that you can use with your own exercise or with the athletes that you're working with. Masks maybe is perhaps the most obvious one, and really it has been barely studied at all. There's a couple of studies that look at comfort of masks, and they're reasonably comfortable. And there's a series of studies led by Langrish et al. That looked at mask wearing during a short walk in Beijing. And they looked at a series of different masks. They found that this one, which is a 3M disposable dust mask, the 8812, seemed to do the best job in terms of preventing pollutants from getting through. And they also found some potential evidence that there's beneficial effects on heart rate variability and systolic blood pressure following this 2-hour walk around Beijing. The caveats were that the participants were wearing their masks for 48 hours around that exercise intervention. And so it's not clear how generalizable it is, but it also gives us sort of a little bit more evidence to really think about the exposure to pollution outside the exercise. A white paper was recently written by the equivalent of the French Ministry of Health, and they analyzed all the evidence around masks and exercise, and they found that there was really no convincing evidence at this point, and so they weren't recommending it during exercise. And so our recommendation in general is in high pollution situations, if you're concerned, wearing the mask around training and competition, not during, may be a good option. Okay, adaptation. So there is a concern or a theory that perhaps you could get used to air pollution and perform better or have less health risks. There's only one study that's relevant to that in terms of particulate matter exhaust air pollution, and it seemed to show that there is no effective adaptation. This is where things get a little bit different, though, is remember we were talking about the recipe of exercise. If the air pollution contains a lot of ozone, the story may be a little bit different. So ozone is different from the typical particulate or exhaust or nitrogen dioxides that we're talking about, because ozone is a secondary pollutant. It's created in the atmosphere. We call it, it's a combination of oxides of nitrogen, hydrocarbons, and sunlight, and the ultraviolet light creates it. And so we see it most late in the day on sunny, hot days is where it gets created. And it seems to be a bit of an irritant. In some studies, it's showing a decrease in lung function, especially in people with asthma or exercise-induced bronchoconstriction. So of all the pollutants, this is the one that seems to have the greatest effect, at least on lung function. And this becomes interesting because we're possibly going to be having the Olympics in 100 days or so, based around Tokyo. And you can see here just about the darkest spot on this map of ozone exposure occurs around Tokyo. So Tokyo is a high ozone environment. And there seems to be some potential adaptation to ozone. There have been a few studies done mostly in the 80s and 90s that showed sort of initially a decrease in lung function over days of exposure, and then an improvement in lung function. There's also a neat study they did a track meet in a high ozone environment, and they looked at where all the participants were based, or their home base, and the athletes from a high ozone environment that came to compete in high ozone did better than those from a low ozone environment. So there seems to be some potential for adaptation specifically to ozone. And we just wrote an editorial about this. It's very speculative because we need to do a bit more research, and we're going to do that, in that a lot of athletes going into the Olympics are going to be doing a heat acclimation program. Our national athletics team is going to be doing that in Gifu in Japan, and to prepare for heat acclimation. But remember, in high sunlight, high heat environments, there's also ozone. And so that may be an opportunity to actually look at ozone levels, time training around both the heat and the ozone, so that you're exposing the athletes to both, if perhaps there's a chance that they can actually acclimatize to ozone. So it's a thought, at least. And so the last strategy worth mentioning would be medications and supplements. And so there has been some concern in the past that medications may make symptoms worse during air pollution. For example, bronchodilators could increase the caliber of the airways and increase the dosage of air pollution. We did some studies in diesel exhaust, showed no negative effects. And at the same time, there haven't been any studies that show any particular beneficial effect in people that don't need bronchodilators. There's one study that shows that Montelukast, singular, in hockey players with exercise-induced bronchoconstriction did get some benefit. However, in ozone, the same thing applies. No negative effects from bronchodilators, but there may be beneficial effects from supplements with vitamin C and vitamin E. There have been a few studies now on this, and with those doses there, 500 milligrams of C and 100 IU of E, there may be both lung function and performance effects. So we really want people with asthma and exercise-induced bronchoconstriction to have maximal control of their symptoms before being exposed to the air pollution, and there may be a role for some of these antioxidant supplements for them. Okay, so sort of take-home medications. Air pollution is bad, so as much as possible, avoid air pollution during training and also outside of training. And if you can separate yourself from the air pollution by time of day or distance, that's helpful. So in Vancouver, early in the day, we have less air pollution. Closer to the ocean, we have less air pollution. So if these kind of strategies are possible, try to employ them. Also, maybe not long, very long, low intensity workouts, because there doesn't seem to be an intensity effect. If you have to train on a high pollution day, we're recommending perhaps consider something shorter and maybe more intense. If you have access to an indoor training environment that's lower in air pollution, that might be an option. But always really minimize air pollution exposure outside of the training time as much as possible. Okay, and then in terms of competition, reassurance. I think that's important. Knowing that the exercise itself doesn't seem to be exacerbating it, doesn't seem to be causing big performance effects. Again, stabilize the asthma, avoid the air pollution as much as possible. These are really important. And if it's a high ozone situation, consider adaptation and perhaps consider antioxidant supplementation. Okay, so just to wrap up, if you don't remember anything from this talk at all, just know that air pollution is bad and exercise is really good. And then just briefly, I'd like to thank all the people that helped with all the research that was done here. And of course, the Institute of Sport and Exercise Health for putting on this conference and making it happen. Thank you.
Well, Mike, thank you indeed for a great presentation, and also thanks for staying up into the early hours to join us for this Q&A session. So I suppose a couple of things really for athletes or people who are worried about their own exposure. Is there any way that you can monitor your own pollution exposure in exercise? I've seen some things on social media of people wearing pollution monitoring devices. Are we going to see a sort of wider availability of those types of devices, and what do you think about their validity?
That's a great question, and something I probably neglected to talk about in the presentation. There's quite a range of personal pollution monitors, and they vary in their reliability and in their wearability, and so there's probably an inverse relationship to that. So the ones that have been shown to be effective are research grade, and they're quite heavy. We did a study, I guess about 18 months ago, with something called the Flow, which was put out by Plume Labs, which is a French organization, and they were really user friendly and really compact and easy to wear. But we actually mounted them next to the Metropolitan Vancouver fixed station sites and compared the data we were getting, and it was just not usable. And so since then, they've created a second generation of them, and there's actually an organization in Southern California that does very systematic analysis of all the wearable devices that are on the market for air pollution, and they also gave that device a very poor grade. So I think we're a couple years away from it, and I think what we're recommending is using either apps or websites that can give decent air quality forecasts, and in a large area, say metropolitan London, there'd be multiple sites across the city where there's fixed station monitoring, and you can look where the pollution is worse and how that's affected by weather, and adjust that way. And that seemed to be more effective than the wearables right now. Kind of the wearables that we're sort of recommending you use is basically just your nose and a bit of common sense right now. Unfortunately, it's kind of a disappointment.
Okay, great. So questions coming in from delegates. There's a question about, does exercise in the rain affect your, I suppose, pollution or ozone exposure? And is that better if you're in a high polluted environment just to wait for it to rain?
Well, that's a great question, because there's two reasons why rain would improve conditions. One is that it actually physically removes some of the particles from the air. So here in Vancouver, our big pollution source is wildfires, so forest fires, and that fills the sky with soot. And then basically the rain will eventually clear it out, and we're fortunate to have a fair bit of that here. And then secondarily, in rainy conditions, it's overcast, so you're not going to get the ultraviolet light that's going to generate the ozone as well. So probably for those reasons, it would be a little bit better. But you can always use forecasts, because there are, in certain conditions on sunny days and certain times of day when the air pollution still is more favorable.
So just as a follow-on to that, I know something you've written or been commented on in the major press is that if people find themselves in a highly polluted environment and they're there for a few days, or they're staying for a week in a city, for instance, should they deliberately avoid exercising at that time if they're concerned about being exposed? Or actually, is it better still to continue to exercise even though you might be exposed to the pollution? How do you weigh up the risks and the benefits if you're an individual in that situation?
Yeah, so that's a tough one, and I think it really it depends on your own health or the health of your patient, and the duration of the pollution exposure. So we work a lot with our colleagues in Sao Paulo, and they're in an unfortunate situation that they just have poor air quality year round. Whereas here in Vancouver, we basically get it for 2 weeks every year during wildfire season. And so I think if in someone in Vancouver where we get extremely bad pollution, but for a short period of time, it does make sense to reduce your training at that time or do more indoor training or shorter intensity. But in terms of long-term health, there's good epidemiological data to show that physical activity remains important from a health point of view in a high pollution environment. And so for people at the other end of the extreme who are in Sao Paulo, we'd recommend that they maintain an active lifestyle and do whatever they can, perhaps recreating in the center of parks, away from major arteries, indoors if it's got good quality air conditioning or filtration.
Okay. We've got time for probably a couple more questions. There's a question about, are you aware of any evidence supporting supplementation with vitamin D in the context of pollution?
I'm not. We haven't found any studies with good evidence on D, just C and E.
Okay. And what about evidence of the sort of quality of interior air quality or pollution? So, you know, thinking about athletes who might be in hotels or, you know, things they can do to try and avoid different environmental triggers within a building.
Yeah, and so it's a extremely important topic, and almost a totally different one because we have separate indoor air pollutants. So things like gas stoves, candle, incense, solvents, paints, glues that we use for carpets. So those are indoor sources. But in a situation where it's a bad air quality day outdoors, if you have access to an indoor environment with good quality air filtration, usually that's related to air conditioning, and you can close the windows and exercise near that filtration unit or air conditioning unit, we'd recommend that as a good alternative, as long as you don't have candles and incense around you. And then cross-country ski waxing, again, is an obvious source of for air quality.
Okay, great. Well, listen, first of all, thanks again for your fantastic talk. Thanks again for joining us so late.
Pleasure.
This kind of brings to the close the first part of this respiratory session. So we're going to take a 15-minute break now. And just to be clear, we're going to be starting the next talk right on 11 o'clock British summer time. So have a 15-minute comfort break, and then look forward to joining you again at 11 o'clock. And thanks again, Mike, for a great talk, and to the other speakers this morning.